Hi, my name is Jessica Alper, and I'm going to present my scholarly project, Implementation of a Nurse Screening Process to Reduce Same-Day Surgery Cancellations. My committee members is Dr. Snell, and my community member is my nurse manager, Stephanie Iannucci. As a background, in a hospital in the Northeast region of the United States, approximately 35% of urology cases were canceled on the same day. There is no current process in place to call patients pre-surgery for urology surgeries. Significance. The purpose of this project was to identify a measure to help reduce same-day surgery cancellations. The aim was to help reduce medical waste by reducing same-day surgery cancellations and help to improve patient, provider, and hospital satisfaction. The project highlights the quality indicators of patient care in the perioperative setting. By identifying a means to reduce same-day surgery cancellations, it is thought that this could incidentally improve patient care, safety, and timeliness for each patient and subsequent patient. Identifying a means to avoid these potential detriments are important for not only nursing care, but also patient care. After an extensive review of the literature, there was found that up to 40% of elective procedures are canceled on the same day. Approximately 18% of these cancellations occur in ambulatory centers, and 50 to 65% of those individuals that cancel have a preventable reason for cancellation. Financially, this turns up to $30 million are wasted due to surgical losses, which is a huge impact on hospitals. In the literature, there were three factors that impacted surgical cancellations. These included patient-related, provider-related, and hospital-related. Patient-related factors are the largest reason for cancellations. These include no-show to surgery, eating, smoking, or lack of transportation can account for these patient-related cancellations. Those with a lack of surgical history have also shown a higher likelihood of cancellation due to anxiety regarding the unknown procedure. These patient-related factors are largely modifiable and can be caught earlier if there was intervention in place to prevent these cancellations. Provider-related factors are somewhat of a non-modifiable risk factor. These include provider illnesses, emergencies, and traumas that require immediate attention and may bump or cancel a surgery that is planned on that day. Allergic reactions to anesthesia, hypertensive emergencies, or hyperglycemic events may cause a cancellation by a provider on the day of surgery out of safety for the patient. Hospital-related factors are non-modifiable factors. These can include inclement weather, such as hurricanes, floods, blizzards, or snow accumulations of a large amount, and these can lead to the cancellation of surgeries. COVID-19 has also led to a decrease in elective surgeries and having a huge impact on surgical cancellations. With same-day surgical cancellations, surgical losses are increased and profits are decreased, leading to a loss of revenue. There is an increase in waste in the OR with inefficient use of space, resources, and the OR staff. The mental well-being of the patient is also impacted with these cancellations. Particularly in oncology procedures, this can lead to an increase in mortality of the patient if the surgery is canceled. COVID-19 cancellations have impacted patients where patients have reported increased pain, a decreased mood, and a reduction in their overall quality of life. Literature has found that interventions are available to reduce same-day surgery cancellations. I found two specific interventions that were in place in the literature: preoperative screening programs as well as pre-surgical phone calls. The preoperative screening programs are available for patients to help optimize them for surgery. It ensures the patient has completed all their prerequisites, such as their medical clearances or referrals to cardiology or pulmonology clearances based on what the patient needs. This helps alleviate the chance that the patient will not have all that is needed in terms of assessments prior to their surgical day. Pre-appointment phone calls have been shown to help alleviate no-show appointments. It allows the patient to be reminded of the time and where to arrive prior to an appointment/surgery. Literature states that dedicated team members who provide calls have shown to help decrease cancellations as it increases the likelihood they will show for the appointment slash surgery. One study in particular showed there was a 54% decrease in surgical cancellation rates for oncology procedures when those patients were provided with a screening telephone call. The theoretical framework that was used for this project was Cotter's 8-step process for change. It helped frame the project and determine if the intervention was successful. The 8 steps are as follows: establish a sense of urgency, creating the guiding coalition, developing a vision and strategy, communicating the change vision, empowering broad-based action, generating short-term wins, consolidating gains and producing more change, and lastly, anchoring new approaches in the culture. Initially, I found a problem in the need as there was no existing intervention to prevent same-day surgical cancellations for urology procedures. The management team helped to create the intervention, which was the pre-surgical phone call, and this was communicated with the staff. If deemed successful, the goal was to be implemented in practice. Wins were visualized through a decrease in same-day surgery cancellations. Cotter's goal was to fix the behavior leading to the problem, and this quality improvement project helped to change the previous practice and behavior and to help to reduce those same-day surgery cancellations. For the scholarly project, the sample was 154 surgical charts of urology patients in a hospital in the Northeast region of the United States. 77 charts were reviewed pre-intervention from August 9th, 2021 to October 2nd, 2021. 77 charts were reviewed post-intervention from October 3rd, 2021 to November 26, 2021. The method/design was a quantitative exploratory design using a retrospective chart review over 16 weeks from August to November 2021. Inclusion criteria were patients 18 to 85 years old that had a urology surgery. They were outpatient and not considered an inpatient within the hospital, and the patients were included if they answered the pre-surgical phone call and were excluded if they did not answer their pre-surgical phone call. Therefore, patients were excluded if they did not meet this criteria. Each EMR was assigned a numerical number on the data collection sheet, and it was documented yes if the patient arrived at surgery or no if they did not arrive at surgery, and therefore the surgery was canceled the same day. Data collection also documented whether the patient answered the pre-surgical phone call. The minimum necessary data was collected to achieve the goals of the project. No patient identifiers were included in the data collection process, and data collection stopped once the DNP student satisfied the inclusion criteria. This method was selected because it allowed for comparison data pre- and post-intervention and helped to answer the question if the pre-surgical phone call helped to reduce the same-day surgery cancellations for the urology procedures. For data analysis, descriptive statistics was used to identify a relationship within the sample set. Nominal data was also used for the pre- and post-test intervention design. The nominal data was used as each EMR was reviewed and assigned a yes if the patient arrived at surgery or no if the surgery was canceled the same day, and this provided the percentage of cancellation rate. The pre- and post-test intervention design was helped to identify a relationship. The parametric test, the z-test for the difference of two proportions, was used to identify if there was a similarity within the analyzed data. SPSS was used with the help of Maryville University provided statistician Dr. Mark Pals, and this was used for data analysis. As you can see, the results of the project was conducted over a 16-week period. 154 surgical charts met the inclusion criteria and were reviewed. 77 charts were reviewed pre-intervention. 77 charts were reviewed post-intervention, which meant after the pre-surgical phone call, for a total of 154 charts total. There was a 90.9% surgical arrival for patients in the pre-intervention group and 92.2% surgical arrival for patients in the post-intervention group. And that post-intervention group were those that received the pre-surgical phone call. In the figure shown above, this was the same-day surgery cancellation. 7 out of 77 patients had a same-day surgery cancellation without the pre-surgical phone call, and 6 out of 77 patients had a same-day surgery cancellation with a pre-surgical phone call. My null hypothesis stated that there was a reduction in same-day surgical cancellations when patients received a pre-surgical phone call. Patients who did receive the pre-surgical phone call did not have a statistically significant lower same-day surgery cancellation rate than those that did not receive the pre-surgical phone call. The p-value was 0.3860, and since it was not less than the significance level, which was chosen as alpha is equal to 0.05, we failed to reject the null hypothesis that there was a lesser rate of cancellation for those with a pre-surgical phone call compared to those without the pre-surgical phone call. In this project, there was some missing data that impacted the latter 8 weeks of the project, and this was when patients received their pre-surgical phone call. Patients were excluded from the study if they did not answer their call. No attempts were made to leave a message, but patients were recontacted if we were unsuccessful on the first round of the pre-surgical phone call. However, this was 100% unsuccessful because each patient that was recontacted did not answer their second pre-surgical phone call. This could have impacted the results because these individuals did not benefit from the pre-surgical phone call, and whether this would help improve that data post-intervention on patients arriving to their surgery. There were some limitations to the scholarly project. The largest limitation was COVID-19 pandemic. This led to the reduction of elective surgeries, which may have skewed the overall results. This is because the surgeries that occurred during the COVID-19 pandemic were more urgent. The patients were likely going to arrive to the surgery whether they received a pre-surgical phone call or not. Another limitation was use of a chart review for the project rather than a randomized controlled trial, because data states that a randomized controlled trial is the ideal design for projects. It was found that there was a small and insignificant change in the reduction of same-day surgery cancellations in those that received the pre-surgical phone call compared to those that did not. We failed to reject the null hypothesis that there was a lesser rate of cancellation for those that received the pre-surgical phone call compared to those that did not, although a small 2% difference was found in the cancellation rates. And this can help to further the decrease in cost for future budgets because the small 2% difference can cause a big impact in financial losses. Literature has shown that pre-surgical phone calls can reduce same-day surgery cancellations. The call was used as a reminder for patients. It gives them the time, what to do, such as being NPO, making sure that they have a ride, making sure they're not sick, and allows them to answer questions. It can also catch any potential issues prior to the surgery day. There were 2 strengths of the project. One is the potential impact in reducing cancellations and improving patient and provider satisfaction and decreasing waste. The other strength was the amount of appreciation that patients felt for getting a pre-surgical phone call. They were appreciative on knowing that they could answer these last-minute questions, that somebody is communicating with them, and overall that they care for the patient. Also, in the fact that this was done through the COVID-19 pandemic, when there was a decrease in visitation policies, it also allowed them to know where they needed to go and where to register and where to go afterwards. Patients will continue to need surgery for the foreseeable future. Identifying a measure to reduce same-day surgery cancellations will help improve patient and provider satisfaction and increase communication between patients and the staff. The future of healthcare will look for measures to reduce medical losses and help to improve patient outcomes and patient care. Technological advances have led to the improvement of reaching patients outside of the face-to-face contact. By communicating with our patients outside of the clinic space, it helps the patient to prepare for surgery/appointments And this will improve the future of healthcare because communication and care is the topmost part of healthcare. In conclusion, in a hospital in the Northeast region of the United States, many urological procedures were canceled the same day. This impacts the hospital, providers, and patients. It increases unnecessary cost and wastes resources. A pre-surgical phone call was implemented to identify if there was a reduction in same-day surgery cancellations for urology patients. Comparison of a pre- and post-intervention / the pre-surgical phone call was used. The project yielded insignificant results, but there was a small decrease in same-day surgery cancellations in patients that received the pre-surgical phone call compared to those that did not. Although it was small, pre-surgical phone calls are being implemented for all surgical disciplines in the practice setting. As even though the scholarly project just looked at urology procedures, it was found that it would be beneficial for all procedures. When looking overall at this project, I would not have done anything different on this project. But in the future, I would look to other technologies to help patients arrive to surgery, such as text messaging or email, or anything else that comes about in the future in technology. Although being cautious on the costs that can incur, such as text messaging on phones, bringing a cost, and then knowing if patients actually look at email or if they do have computers that allow them to, and also if they have smartphones. This DNP program has proved to me that I can complete a project of this caliber. I was able to visualize a problem, find an intervention, and review results, helping to fuel my desire for future research. This program overall has helped me to become a more well-rounded practitioner and know that I can prove and provide a quality improvement project to help improve patient care. Now I will open the floor to questions as I review my references sheets. Thank you.